Dear colleagues, on behalf of Professor Wytske, Fokkens and Professor Valerie Lund, it's my privilege to welcome you to the third of the 3 webinars on EPOS 2020, which is an initiative by the European Rhinologic Society in partnership with Euphoria. These webinars seem to be highly successful, with over 1,200 physicians having registered so far. And today we have a very exciting program with Professor Claire Hopkins informing you about the burden and prevention of chronic rhinosinusitis, Professor Deyun Wang dealing with post-viral and antibiotic use in chronic rhinosinusitis. I will guide you to the EPOS chapter on comorbidities in chronic rhinosinusitis, and it's Dr. Sietze Reitsma from Amsterdam who will deal with children and their problems related to sinus disease. And it's now my pleasure and great honor to introduce to you Professor Claire Hopkins, rhinologist at the University of London in the UK, who will deal and guide you through the burden and prevention of rhinosinusitis.
Thank you very much. I'm delighted to be able to join you all for the series of webinars to present the highlights of EPOS 2020. And I'd like to thank very much our sponsors Novartis, Sanofi, Medtronic and the European Rhinological Society. I've been asked to talk to you about the burden and prevention of acute and chronic rhinosinusitis. Now, perhaps this seems slightly the wrong way around, and really we should be asking ourselves, firstly, can we prevent acute and chronic rhinosinusitis? And if we can't, what's the burden of disease and how do we minimise that? So we think of prevention in 3 different levels. Primary prevention, where we aim to reduce the incidence of disease by identifying risk factors and then reducing exposure to these. Secondary prevention aims to reduce disease prevalence by early detection, symptom control, and preventing future exacerbations. While tertiary prevention aims to reduce the impact of ongoing chronic disease and its complications in order to maintain quality of life and normal functioning as much as possible. And we can see how all 3 of these can aim to reduce the burden of disease on society and the burden of disease on the individual patient. Now, the burden of acute rhinosinusitis in itself is very high. There are more than 20 million cases every year in the US alone. That's about 1 in 10 to 1 in 20 adults having an episode of acute rhinosinusitis every year. Recurrent acute infection is actually much less common, affecting about 1 in 3,000 adults. Both of these together generate a high number of primary healthcare visits, and it's one of the most common triggers for antibiotic prescription, with more than 85% of consultations for acute rhinosinusitis resulting in a patient walking away with an antibiotic prescription. The impact of quality of life on the individual patient is largely overlooked due to its short duration, but where studies exist, they document high levels of pain, nasal obstruction, nasal discharge and headache. And more than 70% of patients report difficulties in performing normal daily activities, resulting in several days of work missed, although generally this is all resolved within 14 days. The burden of chronic rhinosinusitis is much better studied, and we have very good studies looking at prevalence of disease, with an average of about 11% of adults affected across Europe, with much higher rates seen in countries such as Poland, reporting up to 20% prevalence, compared to Scandinavian countries reporting around 7% in Finland. There's a high prevalence of the cardinal symptoms amongst affected patients. When we look at the general population, we see relatively low rates of nasal obstruction and other symptoms. But when we look at patients both in primary care, in a general outpatients, or in those having surgery, more than 90% report nasal obstruction. There are high rates of loss of sense of smell, particularly in those with nasal polyps, and nasal discharge and facial pain are very common. When we look at the severity of the disease, this also shows very high rates, particularly for nasal obstruction and loss of sense of smell. But even with nasal discharge and facial pain, these are scoring at least 2 or 3 out of 5 on a symptom severity index. So it's easy to understand why this has a significant impact on the quality of life of the individual patient. And in a landmark study, Glickler and Metzen showed, using the SF36, that chronic rhinosinusitis has a greater impact on social functioning than either angina or chronic heart failure. More recent studies looking at health utility values have shown that it has a comparable effect to patients with asthma. This results in over 11 million health care visits to a doctor per year in the US and $10 to $13 billion in expenditure. UK studies show that it costs us about £3,000 per patient per year. But this is only the tip of the iceberg, and the indirect financial impact on both the patient and the economy through absenteeism and presenteeism is estimated to be almost double. Now, it's obvious, therefore, that we may wish to try and prevent both acute and chronic rhinosinusitis. And indeed, prevention of disease is one of the key principles of precision medicine. First of all, we want to look at whether we can reduce the incidence of disease by reducing exposure to risk factors or triggers. But unfortunately, for both acute and chronic rhinosinusitis, this has been poorly studied. Now, you've likely already seen this study earlier in the week with Dr. Robert Kern, and we're getting a better understanding about the etiology and pathogenesis of both acute and chronic disease. There's an interaction between host and environment, which allows the endotype to develop. With remodelling, this will then present in the natural history and outcome of disease. So there are many steps where we may perhaps be able to influence this, with primary prevention really looking at the interaction between host and environment, and secondary prevention looking to prevent the remodelling that may occur. Risk factors for developing rhinosinusitis, as I said, have been very poorly studied, but there are some common elements between both acute and chronic disease. Seasonal variation and viral exposure is something that's very much on all of our minds at the moment. And perhaps one small silver lining from the current pandemic is that patients will be much more aware about hand hygiene and how to reduce viral exposure. Smoking, allergic rhinitis, odontogenic infection, and anatomical features are present in both lists. And in chronic rhinosinusitis, we also see risk factors such as asthma, aspirin or non-steroidal exacerbated respiratory disease, environmental pollutants, immunodeficiency, ciliary dysfunction, vitamin D deficiency, microbial imbalance, genetics, and for the first time, EPOS 2020 has shown a link between gastroesophageal reflux disease based on current evidence. Now, I've highlighted the ones in bold that perhaps we have some ability to influence. There is now very strong evidence that smoking is a risk factor for chronic rhinosinusitis. Patients are at increased risk compared to non-smokers, and this is a dose-dependent risk with about a 1.5% increase each year for every additional year of smoking. Unfortunately, passive exposure to childhood also increases their risk of developing chronic sinus disease as an adult. Despite the known risks of smoking, we still have amongst the highest rates of smoking in both men and women in Europe compared to the rest of the world. So we need to use every point of healthcare contact as an opportunity to counsel patients on the importance of smoking cessation. We need to refer patients to smoking cessation services and support this. We need to use taxation as a deterrent, and particularly now as countries look to try and restrict access to healthcare because of financial austerity, which will only become greater after the COVID-19 pandemic. There are talks about perhaps restricting access to surgery for those that continue to smoke, for example, in the UK. The question as to whether allergic rhinitis is a risk factor for either acute or chronic rhinosinusitis remains very controversial in the literature. And for every study that suggests that it is indeed a risk factor, there's another refuting any association. We have no convincing evidence that allergic rhinitis is associated with greater disease severity or treatment failure. We have some weak evidence that treatment of allergic rhinitis does improve outcome in chronic rhinosinusitis. But we as rhinologists know the benefit of effective treatment of allergic rhinitis, and so we should always aim to optimise management regardless of its impact on sinus disease. Odontogenic disease is often overlooked. And in my own hospital, we surveyed patients having sinus surgery over a year and found that in 10% odontogenic disease had likely been missed as a likely cause. Now, this is becoming more common as dental health fails. In the UK, only about 50% of the population have visited an NHS dentist in the last 3 years. And 1 in 3 Americans don't have access through dental insurance coverage. This is resulting in an increasing number of emergency department visits, shown both in the US and Europe, related to dental problems. And certainly we've seen an increase in odontogenic sinusitis in the last 5 years. This has become particularly noticeable in the last 3 months, where as a result of the COVID-19 pandemic, all our dental surgeries have closed in the UK. And we've seen a significant increase in presentations to the ENT department, both with sinogenic complications and also deep space neck infections. The link between occupational exposure to toxins and rhinosinusitis is growing. Previously, there's been a significant paucity of data, but now we have growing evidence to support an association between wood fumes, dust, gas, and steam. We know that certain occupations have an increased risk. For example, farmers and textile workers are an increased risk of developing nasal polyps. And the very high prevalence, 50% rates of chronic rhinosinusitis, has been very well documented in the 9/11 first responders. Recent links show that exposure to particulate matter can increase disease severity, and there's a higher risk of needing surgery amongst patients with chronic rhinosinusitis who have occupational exposure. There's very little we can do as individuals, but it highlights the need for global action to reduce pollution and address climate change, and this is something that our associations must support. Another question is whether chronic rhinosinusitis can result from untreated acute disease. Now, of course, by definition, all sinusitis must be acute, as in lasting under 12 weeks in the first instance. But are they different diseases from the outset? Now, this may be particularly relevant, of course, for type 2 versus non-type 2 disease. And as yet, the studies looking at risk factors haven't really separated patients by different endotype. Bruce Tan's group, using electronic healthcare data, found that patients developing chronic rhinosinusitis were 3 times more likely to have had a preceding episode of acute infection than healthy controls. But as this relies on electronic coding, it may simply reflect that diagnostic dilemma in the early stages of disease. However, there are some studies using repeated aspirates from patients with acute infection that do show a transition in the typical bacterial flora from patients in acute infection to those more typically seen in chronic rhinosinusitis. We have no evidence that use of antibiotics in those early stages can influence the later risk of developing chronic rhinosinusitis. And perhaps there's even a risk that antibiotics may be harmful by changing the microbiome. Now, the microbiome is largely established in the early years of life, so perhaps there is little opportunity to influence that at a later stage. But we've seen reduced diversity in patients with chronic rhinosinusitis. This is also seen after treatment with antibiotics, and antibiotics may indeed have prolonged effects, particularly if given in childhood. We know that a non-sinusitis-related antibiotic exposure is associated with an increased risk of developing chronic rhinosinusitis, about twice that of those patients that haven't had any antibiotics at all. So what can we do? Well, ENT conditions have very high rates of antibiotic usage, particularly acute rhinosinusitis. We know that this is very common and usually self-limiting. And we have good evidence from a large number of high-quality trials that there is very little benefit from antibiotics, both in terms of the speed and rate of recovery. But as I've said earlier, 85% of GP consultations result in a prescription. So we really need to support and educate our primary care doctors in withholding antibiotics. We need to offer supportive treatment except in the presence of complications. Secondary prevention involves reducing disease prevalence by early detection, symptom control, and preventing future exacerbations. And really that sums up the essence of EPOS 2020. So I think if we can all really engage with the guidelines and follow them as best as possible, we will achieve very good levels of secondary prevention. We discuss in EPOS better diagnostic criteria and appropriate use of interventions to allow early diagnosis. We describe personalised care according to endotype. And as you can see, we're introducing concepts of type 2 and non-type 2 inflammation, so we can really move forward towards this personalised care. We want to better identify poor disease control, so we know when to escalate care. And this in itself will allow more timely use of surgical intervention. We have some evidence that significant delays to surgical intervention may actually be detrimental to the final outcome. We want to identify those patients who will fail to benefit from conventional pathways at an early time point, so we know who will derive the greatest benefit from new treatments such as biologics. But we still need research to define the role of early intervention as a disease modifier. We traditionally follow a step-up pathway of care, so we always start with the baseline and build on this if patients fail to respond. But perhaps we need to have an opposite approach in some patients who we can predict will have a poor outcome, and perhaps have a step-down approach, start with the greatest level of intervention, biologics for example, perhaps in the hope that this will change the future course of their disease and reduce the risk of future exacerbations and chronicity. Tertiary prevention involves the reduction of the impact of ongoing chronic disease and its complications in order to maintain quality of life and normal functioning as much as possible. It's estimated that despite good evidence-based care, about 30 to 50% of our chronic rhinosinusitis patients will remain uncontrolled, and this clearly will have a significant impact on their quality of life. We need to look at factors that may predict poor control. They may be disease-related, and we may have little ability to influence underlying genetic and endogenous factors. They may be diagnosis-related. First of all, we need to confirm that we have the incorrect diagnosis. I often see patients who have facial pain unrelated to sinus disease referred as a recalcitrant chronic rhinosinusitis patient. These patients have often had multiple courses of antibiotics and often several surgeries with no improvement in symptoms because the diagnosis is wrong. There may be failure to identify concomitant local or systemic disease, or simply inadequate management of that associated disease itself. There may be failures in treatment. We may be giving the wrong treatment or simply inadequate treatment for the right length of time. There may be patient-related factors, exposure with poor compliance with treatment, and this is a very common problem. There also may be ongoing exposure to environmental irritants, smoking, occupational irritants that we haven't yet addressed. Patient compliance is a significant problem. There's a nice study from Luke Rudnick's group looking at patients with chronic rhinosinusitis with a prescription for intranasal corticosteroids. Only 20% of patients were actively using their steroid sprays. And when they looked at the number of prescriptions, it seems that patients were only using about 25% of the dosage that they were recommended. It's likely that this is a combination of both poor compliance and underprescribing. Now, there's some interest in using digital healthcare apps to promote self-management and increase compliance. And on the screen, you can see the view from the mysinusitiscoach.com app. It encourages patients to rate their symptoms on a daily basis so that you can see quite clearly when control is deteriorating, to prompt patients to better comply with their medications. Now, these have been shown to work well for about 3 months, but then the patient simply becomes non-compliant with the app. So it's a very difficult problem to solve. We can use handwritten and signed patient contracts to really engage patients in the importance of their input to their own care. And perhaps we'll move more to the use of slow-release drug-eluting stents to deliver steroids, antibiotics, or other agents directly into the sinuses without active involvement from the patient. We need to be better aware of the risks of our treatments too. This is slides from a patient of mine with a vascular necrosis of his femoral head, but not from oral steroids as you might expect, but from simply topical fluticasone because it interacted with his HIV medication. This is a very rare interaction and it can be very difficult to keep up with the literature, but this is what EPOS 2020 is here to do for you, to highlight some of the problems with the medication that we give. And it is easy to overlook. With intranasal corticosteroids, we wish to minimise systemic absorption with modern formulations such as mometazone or fluticasone, but I'm surprised by the significant number of patients who are still prescribed beclomethasone with 40% bioavailability, simply because it's cheaper. We need to counsel patients about the risk of contamination with saline rinse bottles. They need to clean their bottles and consider their water supply so that we don't get newspaper headlines of brain-invading amoeba, which have been described in the US. We still don't know what a safe dose of oral steroids will be, or how often this can be repeated without a significant risk of complications. We know that antibiotic resistance is one of the greatest healthcare challenges facing the modern world, but we don't know the impact on the individual sinus microbiome. And there are other risks of antibiotics that we often overlook. Some case control studies have shown that there's an increased risk of myocardial infarction in patients receiving macrolide antibiotics. So as part of the macro study, we looked at over 300,000 antibiotic prescriptions, over 60,000 different patients with chronic rhinosinusitis. And we also found that there was an increased risk in the short term of myocardial infarction and arrhythmia, affecting about 1 in 1,000 patients prescribed. Now, this is about the same as a major complication from surgery, but most patients, and I think most physicians, would normally think that antibiotics were a much safer option. We need to think also about reducing risks of complications from surgery through better training, advances in instrumentation, optimising the surgical field, and perhaps better use of image guidance and augmented reality. Now, I say perhaps because there is still no strong evidence that this can reduce the risk of complications. And indeed, in some cases, I think it's used as a substitute of sound training, knowledge of anatomy and experience, and it might encourage surgeons to take unnecessary risks. But things are improving all the time, and augmented reality is looking at ways, for example, to alert the surgeon if they're approaching the skull base, to cut off powered instruments. And I'm sure in time these will become very valuable tools in making surgery safer. We also need to manage patients' comorbidities. We know there are very high levels of depression and anxiety found in patients with chronic rhinosinusitis. Chronic rhinosinusitis patients with coexisting depression report higher symptom scores despite the same level of disease on CT. And although they benefit from treatment to the same effect, their symptom scores remain much higher because of that underlying disease. So we need to engage our primary care physicians and other physicians involved in our patients' care to better manage these coexisting conditions so that our patients can get the maximum benefit from the treatment that we offer. I haven't got time to go through any other risk factors, but hopefully we've looked and given you a good overview of some of the aspects of prevention mentioned in EPOS 2020. We've talked about primary prevention, reducing the incidence of disease, secondary prevention, to try and reduce disease prevalence by early detection and good symptom control, and tertiary prevention to reduce the impact of ongoing chronic disease on its patients. Hopefully this will soon be able to reduce the disease burden on both society and our individual patients. Thank you very much for your time. So we've had some questions in from the audience already. So the first question we've had in is, what do you think the future of personalised management is? And what is the role of electronic healthcare apps in integrating that? Well, I think certainly we're seeing people engage with their phones when they're training in fitness and health, counting their steps. And I think we need to integrate the whole aspect of healthcare into Fitbit smartphones rather than having separate build-on apps. But we really need to engage patients much more in their self-management. I think too many patients at the moment come to the doctor, expect us to solve their problems, and then fail to take their own part in that. And we've already seen that compliance is very poor. And so I think, engaging in patient contracts, you can get patients to sign on behalf of what they will bring to the partnership, and really show them that this is a partnership and that they have to do their own bit to improve their quality of life, particularly in chronic rhinosinusitis, is extremely relevant. The next question we've had in is, how does occupational or environmental exposure to irritants influence your therapeutic approach in chronic rhinosinusitis? Now, I always ask my patients about history of smoking, exposure to irritants at work, but it can be very difficult to influence their exposure to that. Particularly, for example, I saw a patient yesterday whose job involves exposure to solvents and chemical irritants on a daily basis. Now, at the moment, the evidence suggests that the benefit from surgery is still in the same range of improvement in patients who have occupational exposure. It's just that we start at a more severe point and then are still at a more severe point at the end. So I think it's wrong to exclude patients from treatment, but we need to find ways to minimise their exposure as much as possible. As I said, I speak to patients about stopping smoking at every point in contact. The next question is how we can convince our respiratory care physicians about the preventative potential of FES. Well, I think we need to work with them. We need to do joint clinics together. A lot of our respiratory physicians, for example, will overlook polyps, but we've got really convincing evidence that, for example, patients with polyps have more acute exacerbations of their asthma. So we need to show them that we can improve their asthma care at the same time and work together to really help deliver a unified airway approach. So I think that will be very important. I've been asked about Sinuva. Now, we don't have that yet in the UK, so I won't specifically talk about that, but I think that was covered by Professor Kern yesterday. Another question we've had in is, how do we convince payers and research providers of the importance of the burden of chronic rhinosinusitis? And I think it's really down to us as researchers to collect that data with all our studies, and as clinicians to capture that data with every patient interaction, so we have that body of evidence. I think perhaps another silver lining that might come out of the COVID pandemic is that Many of our funders will now have some experience of having lost their sense of smell, so it might be easier to convince them of the impact that that has on our patients. But we really need to harness data to be able to convince people of the importance of paying for the care that we deliver. So thank you very much for your attention for my session. I have great delight in being able to hand over to Professor Deyun Wang from the National University of Singapore, and he will talk to us about the importance of the avoidance of antibiotics in post-viral acute rhinosinusitis. Thank you.
Dear colleagues, friends, ladies and gentlemen, greeting from Singapore. First, I'd like to thank the organizing committee of Euphoria EPOS webinar. And I also like to especially thank Professor Wytske Fokkens and Professor Valerie Lund for their leadership and extremely hardworking on this document. Also to the member of EPOS guideline members and contributors to the success of this document. And in coming 15 minutes, I'm going to present the post-viral rhinosinusitis, and I will try to convince you why we should not use prescribed antibiotics. For the definition of acute rhinosinusitis is very clear, remain the same as a previous document. So means it must be the sudden onset of 2 or more symptoms. For adult, one of them must be nasal blockage or nasal obstruction or nasal discharge, and then have facial pain, pressure, and reduction or loss of smell. For the children, it must be 2 out of 3, the most common symptoms like nasal obstruction, discolored nasal discharge, and also cough. So the duration of this acute rhinosinusitis should be less than 12 weeks. This figure shows clearly the definition of acute rhinosinusitis. We know all starting from common cold, means viral rhinosinusitis. Usually the symptom lasts about 5 to 7 days. And then some patient symptom can last longer, a little bit longer, about a few days or even week longer. For instance, like nasal discharge, cough, and nasal obstruction. And this patient, most we can see contribute to this post-viral rhinosinusitis. And of course, some symptom, a small group of patients can increase symptom after 5 days or persistent after 10 days, especially if they present the fever or double sickening or unilateral disease, several severe pain, and also raised ESR and CRP in the blood. So this group, if they present at least 3 of these symptoms, they maybe can be diagnosed as acute bacterial rhinosinusitis. So these figures summarize the pathogenesis of acute rhinosinusitis. As we can see, almost all respiratory viruses will first attack nasal epithelium, where they start replication and increase the number of viruses, and then to invade all other cells, tissues, and organs. And then from epithelium, we can see the damage of epithelium structure and also the dysfunction, like cilia loss, altered cilia function, increased mucus production, and also barrier breakdown. So meanwhile, the epithelial cell also switch on all these some sensory receptors and also signaling pathways like toll-like receptor 3, 7, ICAM1, REC-I. All these are important for the infection. And meanwhile, epithelial also produce large amount of type 1, type 3 interferon, and also transcription factors and cytokine, chemokine. Some are known like IL-6, IL-8, CX, IL-10, 11, and rhinitis. So these factors will activate the early innate immune system and also to cause mucosal inflammation like inflammatory cell migration, activation, and this will last again about a few days, even week, to be completely resolved after the infection. Therefore, this together with the epithelial damage, this will contribute to the symptoms of post-viral rhinosinusitis. Of course, some group or smaller group of patients will have a secondary bacterial infection, and then we'll end up with the acute bacterial rhinosinusitis. So for the prevalence and incidence of acute rhinosinusitis, this has been reported by several studies in different ways, but one most recent is 2018 by Kaufman and colleagues. This is a well-conducted study, respective population study in Dutch population. So from this study, they used the EPOS guideline, the definition. So the prevalence is about 18%. It's quite similar, a little bit higher than other report, but this is probably more accurate, representing the more true prevalence and incidence. We all agree that rhinosinusitis can be divided into 3 groups. The first one is the most common one, acute viral rhinosinusitis, means it's almost all common cold. And then also the second group is acute post-viral rhinosinusitis. And then the third group is a smaller group, is about acute bacterial rhinosinusitis. It's estimate about 1 or 2%. There are few important highlights, such as post-viral acute rhinosinusitis is a common condition in the community, usually followed by common cold or URTI. And then the most evidence shows that antibiotics treatment does not prevent complication. And then because this disease is self-limiting. And then, of course, in small group of patients, they may have a bacterial infection. But in most cases, antibiotics have little or effect on the cause of the illness. And then we all know antibiotics overuse or antibiotic abuse and misuse. This is a common worldwide medical problem. But if we look back to the rhinosinusitis, actually this always remain in the top few reasons of this common diagnosis and where antibiotics is prescribed. And just give an example of the study 2002, rhinosinusitis in United States, which account about 9% in pediatric and 21% in adult antibiotics prescription, respectively. We also performed a study about 10 years ago in Asia. So we surveyed on the management of acute rhinosinusitis among Asian physicians, and which include GPs, ENTs, and also pediatricians, where we can see that even in a mild common cold, and then the doctor will, about 30% physicians will prescribe antibiotics. This figure going up to 40% and 60% and in moderate and severe symptoms. And of course, the many doctors feel bacterial rhinosinusitis maybe happens, but actually the overdiagnosis happens. This contributes to the overuse of these antibiotics, which can go up to 60%. Again, the reason of antibiotics use, and some doctors feel that antibiotics use can prevent the development of complication of acute rhinosinusitis. But based on evidence, actually the answer is not. There's only little or even no effect. And then of course, antibiotics in some patients can be used, but sometimes the poor patient selection also increase the misuse of antibiotics and also contribute to the unwanted antibiotics resistance. There's a good study published in Fokkens analysis. This study includes 11 studies. 6 of them include a patient with a common cold, and 5 studies include purulent rhinitis. And then they perform combined analysis to look at the effect of antibiotics treatment in the common cold and this purulent rhinitis. In general, the conclusion is there's no effect of benefit from antibiotics for this common cold and also for the persistent acute purulent rhinitis in both children and adults. But on the other hand, there is increased significantly the adverse the effect in adults and also in some of the children's. So this is a very interesting result. And also in this new EPOS 2020 have increased 7 studies which look at adult patients with acute post-viral acute rhinosinusitis and then compare antibiotics versus placebo and then look at association with great cure at day 10 and 14. Actually, if you see the overall result, actually there is not significant difference. The difference is very small. But if you look at the other side, actually this contribute to the more adverse event. And then we can see it's almost increased about 30%. This is an adult study. There are also 4 studies performed in children. Same study, they look at the acute post-viral rhinosinusitis, compare antibiotics and placebo, and look at improvement at the day 10 and 14. Again, the effect, the difference is very small, not significant. But also, on the other hand, we do see more adverse event. This happens in together is again about 30% increase the adverse event. So therefore, in the general conclusion of this EPOS 2020, and there is no benefit of prescribing antibiotics for post-viral acute rhinosinusitis in both adult and children. And there is no effect on cure, even also for the duration of disease, and then, but increase more adverse event. And then based on the moderate level of evidence, actually we all proven well that this acute post-viral rhinosinusitis is a self-limiting disease. And therefore, EPOS 2020 steering group advised against the use of antibiotics for both adult and children in this situation. Thank you. Thank you. So for the question, the first question, is there any typical symptoms and underlying pathogenesis of post-viral rhinosinusitis? As I mentioned before, in the slide, so all acute rhinosinusitis start from common cold. So usually the common cold will resolve, the symptom will become during 5 or 7 days. But we can see in some patients, the symptom can be last for a few more days, even can last for 1 or 2 weeks more. So I from my personal belief, this group of patients are really contribute to this post-virus acute rhinosinusitis. But actually, since we are being studying the pathogenesis underlying the disease, and actually we do see after the common cold, there is epithelial damage, and also this dysfunction like cilia, mucus production. All these will need to be resolved about more than a week. And then also the underlying inflammation, activation, migration of inflammatory cells. So this will take about a few days and a week. So I think this group of patients are more belong to this post-viral acute rhinosinusitis, if I understand well. So it means this patient has symptoms, but they still on the way to be resolved, and then takes about 1 or 2 weeks. And another question is quite interesting, and talking about why is the term of ARS instead of AVRS with a V for viral, for following the terminology of ABRS. Yeah, very good suggestion. So probably this one will address back to the chairman, Professor Fokkens and Valerie Lund, and we'll see whether we can work on. But actually, in the literature, we've been using this ARS and then ABRS and quite common. So probably we're just using this term and basically just follow the common term. So I would suggest this to Professor Fokkens. And then the third question is, why didn't we succeed in reduced AB, used in CRS up till now. What did we do wrong so far? Nothing wrong. And then just terminology. So yeah, we probably will think about this and see whether we can make this more clear. The last question, if not all acute bacteria rhinosinusitis requires antibiotics, then which ones do? Yeah, we will say antibiotics actually is not the only one treatment. And then why some patients, even who do not need antibiotics but benefit from the symptom, because we all know antibiotics has this anti-inflammatory effect. So therefore, recently, even since the previous EPOS guideline, we already recommend for using the nasal steroid and also some symptomatic treatment, which all, if you are anti-inflammation, which can improve symptoms, that will be better by using the antibiotics, because if patients are not necessary to be used for antibiotics, we should not. I will leave all the questions at the end to the panel discussion, but I'd like to introduce Professor Peter Hellings. I'm sure everyone knows he's come from Belgium, from the University of Leuven. So he's going to discuss these comorbidities of CRS, please.
Dear colleagues, it's my pleasure and great privilege to guide you through the chapter of EPOS 2020 on CRS and comorbidities, because any neglect of these comorbidities has a major and negative impact on CRS diagnosis and outcomes. The comorbidities that I would like to share with you and that have been extensively dealt with in the EPOS 2020 document are allergies, immunodeficiencies, lower airway diseases, cystic fibrosis and primary ciliary dyskinesia, fungal rhinosinusitis, and vasculitis and granulomatous diseases. I will guide you one by one through what I consider to be relevant to be shared with you in this excellent EPOS 2020 webinars that are provided by the European Rhinological Society in conjunction with Euphoria. When we talk about chronic rhinosinusitis and allergy, we are mainly dealing with three entities: allergic rhinitis, central component allergic disease, and allergic fungal rhinosinusitis. Each of these entities requires some attention, and I would like to go deeper into each of them. First of all, allergic rhinitis is very common. We know very well the pathophysiology underlying the inflammation at the nasal mucosa, and some subgroups like chronic rhinosinusitis with nasal polyps share a common immune pathway with allergic rhinitis, where inflammation is being driven by T helper 2 lymphocytes. Also, in patients with nasal polyps, there are not only T helper 2 lymphocytes present, but also local polyclonal IgE production, driving inflammation and giving rise to the chronicity of disease as we see it in nasal polyp patients. What we generally accept is that allergy aggravates chronic rhinosinusitis severity, and quite often it's a challenge to estimate the relative contribution of perennial allergen sensitization to the CRS phenotype. In pollen allergy, this seems to be very obvious when CRS patients experience increase in sinonasal symptoms during the pollen season, but in those patients sensitized to house dust mite or to fungal allergens, the perennial nature of these allergens make it often challenging to estimate the relative contribution of desensitization to the disease severity. What is good to know, and what is often a misperception among a significant group of non-ENT doctors, is that allergy is a risk factor for chronic rhinosinusitis, which does not seem to be the case. However, some associations exist between sensitization to inhalant allergens and chronic rhinosinusitis. And since EPOS 2020, several studies have been undertaken looking at the sensitization prevalence and profile of patients presenting with chronic rhinosinusitis with and without nasal polyps. And depending on the nature of the center and the profile of the center where these studies have been conducted, the sensitization prevalence was up to 50% in patients with chronic rhinosinusitis with and in some also without nasal polyps. I do like very much the study of Carl Philpott in the UK, where prevalences of sensitization are reported in up to 1/3 of patients with chronic rhinosinusitis, which also reflects and mirrors what I see in my rhinology clinic. Having said that, we all know and recommend anti-allergic treatment in those patients affected by chronic rhinosinusitis when comorbid allergy is there. And we are all aware of the treatment options of allergic rhinitis being allergen and irritant avoidance if possible, pharmacotherapy with antihistamines, nasal steroids, and a combination of both, and allergen-specific immunotherapy in case of severe uncontrolled allergic rhinitis. A recent novel entity in the field of allergic disease and CRS is the so-called central compartment allergic disease. It has been reported recently as a variant of chronic rhinosinusitis and is described as a polypoid edematous change of the middle turbinate, but with also some other structures like the posterior septum and the superior turbinate being involved. It seems like patients with these polypoid edematous changes of the middle turbinate and other structures inside the nose present with a high sensitization rate to inhalant allergens. This entity, this novel entity, may become more relevant in the future, but further studies are needed to validate the etiology and also the clinical course of this entity that is still not fully understood. A third entity in the context of allergic rhinitis is allergic fungal rhinosinusitis, and I will deal with that entity in the chapter on fungal disease and chronic rhinosinusitis. When we talk about immunodeficiency in the context of chronic rhinosinusitis, we distinguish primary and secondary immunodeficiencies, and we are all aware of the fact that primary immunodeficiencies are subdivided in those where the humoral system is affected, the cellular immune system is affected, or the innate immune system is deficient. Secondary immunodeficiencies are seen more frequently than before in association with general medical conditions that affect the immune system, immunosuppressive treatment, and also in HIV-infected patients. Considering chronic rhinosinusitis and immunodeficiency, we distinguish between primary and secondary immunodeficiencies. Primary immunodeficiencies can be found at humoral, cellular, and innate immune level, and secondary immunodeficiencies are associated with general medical conditions, immunosuppressive treatment, and HIV disease. Primary immune deficiencies, especially immunoglobulin deficiencies, are highly prevalent and can be found in 1 out of 4 patients with severe or difficult to treat chronic rhinosinusitis. Despite some bias in reported prevalence, we do recognize several subtypes that are listed here. The common variable immunodeficiency and selective subclass immunoglobulin deficiencies are the most reported immunodeficiencies found in CRS patients. In the EPOS document, there is the clear statement that in patients with chronic rhinosinusitis suspected of having a humoral immunodeficiency, a measurement of serum immunoglobulin level is the key investigation, and that sounds very logical to us. And in suspicion of a humoral immunodeficiency, referral to a clinical immunologist is the best way forward, because it's of paramount importance that the diagnosis and its complications are established in close collaboration with clinical immunologists, as they can evaluate the availability and the indication of substitution treatment. When it comes to treatment of immunoglobulin deficiencies, there are few controlled trials, and within the EPOS 2020 chapter on immunoglobulins, we find extensive information about efficacy and caveats of immunoglobulin replacement therapy, prophylactic antibiotics, pneumococcal vaccinations in case of low immunoglobulins to pneumococcal serotypes, and also the position of sinus surgery. It does make sense in chronic rhinosinusitis patients with comorbid immunoglobulin deficiency to open the sinus cavities and to make sure that that part of inflammation at least is properly dealt with. Secondary immune deficiencies should not be neglected, as the prevalence of these type of immunodeficiencies are rising because of the availability and the clinical implementation of immunosuppressive agents for patients with systemic immune disorders and autoimmune disorders, and therefore we should also think of these secondary immune deficiencies when a patient with difficult to treat or very severe chronic rhinosinusitis presents to us in daily practice. Talking then about chronic rhinosinusitis and lower airways disease, we recognize two specific entities. On the one hand, we have asthma, on the other hand, chronic bronchitis and bronchiectasis. It's obvious that every ENT doctor dealing with chronic rhinosinusitis asks his or her patient about history of bronchial symptoms, considers a lung function test in case of a positive history, as we are often confronted with an underdiagnosis of asthma, underdiagnosis of chronic bronchitis in patients with chronic rhinosinusitis. And we do recognize that there is a nasal-bronchial interaction that is responsible for the impact of the upper on the lower airway inflammation and vice versa. And this scheme nicely conceptualize what this means, this nasal-bronchial interaction. In the case of upper airway inflammation, as we see in rhinosinusitis, but also in rhinitis, there is a trigger of inflammation also going to the lower airways via the neural pathway, the systemic pathway, and even with epithelial dysfunction in both parts of the airways, affecting the upper and the lower airways. And what is important to know is that ENT doctors should not only be aware of the EPOS 2020 recommendation for care for CRS, but also be updated about the GINA guidelines, allowing optimal treatment for patients with CRS and comorbid lower airway diseases. And I cannot stress enough that the presence of asthma and chronic bronchitis has a negative impact on CRS severity and also vice versa. And also, we know that there is a positive impact of CRS treatment, including sinus surgery, on asthma, chronic bronchitis, and bronchiectasis outcomes. Extensive studies have been performed showing the multiple benefits of proper upper airway care in patients with comorbid lower airway diseases. Coming then to cystic fibrosis. Most of you are aware that this is a genetic condition affecting the chloride channel, and there are several mutation classes being reported, and I list here the 6 classes without going into detail. But in children and adolescents with bilateral nasal polyps, this phenotype is a clinical indication of a mutation of the gene affecting the chloride channel. And nasal polyposis in cystic fibrosis patients becomes more common as children age, with a prevalence of up to 50% in adolescent patients with the genetic mutation. About cystic fibrosis and the novelties that are included in EPOS 2020, I summarize here the novelties in this key point slide. And the novelties relate to the high concordance of bacteria cultured from the paranasal sinuses in these patients with cystic fibrosis and the bacterial flora in the lower airways. This high concordance is important because it allows a tailored and a personalized treatment for these patients that are prone to infections. National screening programs have been developed and implemented with success in several countries worldwide, and gene-based therapeutic agents like ivacaftor seems very important for the future in care of these patients. And the use of topical antibiotics correlate with the improvement in symptom and endoscopic scoring in uncontrolled studies, in uncontrolled cases, and seems to be a safe treatment for these patients with cystic fibrosis. Also, some studies would recommend sinus surgery in the cystic fibrosis patients as a source of infection in the upper airways should be prevented, especially in those with severe lung disease or in those in consideration for lung transplantation. Coming then to primary ciliary dyskinesia, which is to some extent close but also different from cystic fibrosis. Primary ciliary dyskinesia is a collection of rare inherited disorders that affect motile cilia, leading to a deficient or absent mucociliary clearance. Whenever nasal polyps are evident on nasal endoscopy of a child, we not only consider cystic fibrosis, but also primary ciliary dyskinesia. And some conditions support diagnostic testing for these patients. We think of PCD whenever there is a situs inversus plus respiratory or nasal symptoms, when there is neonatal respiratory distress of unknown cause, when there is a sibling with PCD, when there is daily lifelong wet cough. If considering testing for CF, also considers testing for primary ciliary dyskinesia, and these tests can go from a screening with nasal NO to evaluation with electron microscopy of the cilia and the microscopic structure of the cilia to ciliogenesis in vitro. So there are several diagnostic tests that can be considered, and they should be taken care of, or they should be implemented whenever there are these conditions present. Also, unexplained bronchiectasis supports diagnostic testing in PCD, serosotitis media in association with lower and upper airway symptoms, and cardiac disease associated with heterotaxy if there is suspicion also of respiratory and other problems. In EPOS 2020, we have included that nasal nitric oxide, and especially very low nasal nitric oxide levels, are really a very good screening tool for the diagnosis of primary ciliary dyskinesia, and would encourage physicians to go one step further in the diagnostic procedure. Coming then to fungal rhinosinusitis, which is often considered a very hot topic, but before going into details, I need to remind you that fungi are everywhere in the noses of the healthy persons, as well as in noses of patients with severe chronic rhinosinusitis, as well as in the environment of all people. Fungi may, however, become pathogens when immune responses are evoked in the host. And the definition and characterization of fungal rhinosinusitis is still controversial. And this is a quote still of EPOS 2020. But what makes you very well understand what fungi are all about in the context of chronic rhinosinusitis, it's good to distinguish three different entities based on the underlying immune response to fungi. If there is a hypersensitivity to fungi in a specific context, we may consider the diagnosis of allergic fungal rhinosinusitis. In an immunocompetent patient where there is a localized infection in the sinus, this may be a fungus ball, and in patients with immunosuppressants, we may define the presence of an aggressive fungal rhinosinusitis as invasive fungal rhinosinusitis. And I will highlight these conditions more with the criteria. So a fungus ball is a collection of fungus debris, usually within one sinus. There is a female predisposition of patients in middle age. It mainly affects the maxillary and the sphenoidal sinus cavity, and surgery is the treatment of choice. Allergic fungal rhinosinusitis is a subset of polypoid chronic rhinosinusitis with some features. There is eosinophilic mucin with non-invasive fungal hyphae and a type 1 hypersensitivity to fungi. Overall, the EPOS 2020 expert committee agrees that the prevalence of allergic fungal rhinosinusitis may account for up to 10% of the CRS cases, with certain areas in the world having a higher prevalence. But there is still controversy about allergic fungal rhinosinusitis being a distinct clinical phenotype from chronic rhinosinusitis with nasal polyps. And the future will tell us that when we go further into mechanistic studies and also refine diagnosis in daily practice and routine. 5 major criteria have been considered of importance for defining allergic fungal rhinosinusitis. Should be about bilateral nasal polyps, fungi on staining, eosinophilic mucin without fungal invasion in the sinus tissue, type 1 hypersensitivity to fungi, and some characteristics CT scan findings. Minor criteria that would add to the diagnosis of allergic fungal rhinosinusitis are bone erosion on CT scans, charcoal-laden crystals during harvesting of secretions and evaluation on histology, what is present in the sinonasal cavities, unilateral disease, peripheral eosinophilia, and a positive fungal culture, along with some other criteria where I won't go into detail because they are extensively reported in the full EPOS 2020 chapter on allergic fungal rhinosinusitis. What is important to share with you is some clear statements on the treatment of allergic fungal rhinosinusitis, be that unlike the management of classic rhinosinusitis, allergic fungal rhinosinusitis is mainly treated with surgery, as the medical treatment alone is usually ineffective in these patients, and that's good to remind you all about. Then I come to a last entity of fungal chronic rhinosinusitis, which is the invasive form, almost exclusively found in immunocompromised patients, where fungal hyphae can be found within the mucosal tissue, explaining the reason why this is called invasive. On the other hand, this is often a severe condition that is even life-threatening, also explaining why this is called invasive fungal rhinosinusitis. It's often found in immunocompromised hosts, like those with diabetes or hematologic malignancies, and there are 3 key principles of treatment: systemic antifungals, endoscopic surgical debridement of the necrotic sinonasal tissue, and also try to restore the immune suppressive state of the patient if possible and feasible, in discussion with the hematologist or the internal medicine doctor or whoever takes care of the patient with the immunocompromised state. A final and important entity and comorbidity of chronic rhinosinusitis is the group of patients with vasculitis. This is a heterogeneous group of patients with a complicated and complex systemic disease, and the nomenclature on vasculitis has been revised and is now based on the affected blood vessel size. This nomenclature has limited clinical applicability, and I'll share it with you in a minute, but we talk mainly about ANCA-associated vasculitis like granulomatosis with polyangiitis, previously called the Wegener's disease, or eosinophilic granulomatosis with polyangiitis, previously called Church-Strauss syndrome, and microscopic polyangiitis. This is a mouthful, and you find also the full overview of the different conditions affecting different sizes of the vessels within the EPOS 2020 document, and I'm happy to share with you the full list of these vasculitis entities. And it's good to realize that we think of vasculitis in those patients with severe chronic rhinosinusitis, with mainly crusting, general malaise, facial pain, and multi-organ involvement. A positive ANCA test with raised erythrocyte sedimentation rate and CRP must ring a bell in physicians treating these patients, and also CT scans showing bone erosion and thickening, severe thickening of the bone. Histology is also a confirmation of the diagnosis and helps us to properly treat patients with vasculitis. Regarding vasculitis, and I come now to one of the last slides of this session on comorbidities and chronic rhinosinusitis, there must be a low threshold of suspicion when we think of vasculitis in patients with chronic rhinosinusitis, and we should go for ANCA testing in case of severe cases that have a speedy progress and with general malaise and crusting as important phenotypes. It's good to realize that cocaine abuse can also produce midline destructive processes that may mimic granulomatous vasculitis conditions. Sarcoidosis is also a multi-system inflammatory condition with an unknown etiology that should be taken care of and not be neglected, and that systemic steroids remain the mainstay of treatment in these cases and should be discussed as one of the treatment options with your colleague from internal medicine of any colleague familiar with systemic immune disorder. Local treatment options are recommended given the treatment and the local inflammation. And for ENT physicians, it's good to know that nasal douching, rinsing, topical steroids, and lubricants are recommended in these patients with vasculitis. Having said that, I hope I have guided you through the chapter on chronic rhinosinusitis and comorbidities. I could not deal with all details and all relevant information that may help you in daily practice, but I do hope to have given you an overview of what can be found in the latest update of the European position paper on rhinosinusitis and nasal polyps. And I thank you for your attention. Thank you for your attention, also for sending your questions. I'll try to guide you through some of the questions we received. And there is a substantial number of questions related to the correlation between allergic rhinitis and chronic rhinosinusitis. It's all about the possibility to endotype. It's about the correct diagnosis and also the implication of allergic rhinitis being found in a patient with chronic rhinosinusitis. But coming back to the initial point, allergic rhinitis and chronic rhinosinusitis have overlapping symptomatology. Their patients come to see us for. They have a common type 2 inflammation driving, on the one hand, the IgE-mediated reaction in the nasal mucosa in allergic rhinitis, as well as the type 2 inflammation that we see in patients with type 2 inflammation in chronic rhinosinusitis, as we see in nasal polyps. And it's good to just treat both under optimal conditions. When there is inhalant allergies, we should indeed follow also recommendations for proper anti-allergic treatments. I won't go into detail, but I was always struck by one of the studies that came to my attention where patients with chronic rhinosinusitis and comorbid allergic rhinitis had better outcomes after sinus surgery when they had been on allergen-specific immunotherapy, which reduced the degree of inflammation that was not ongoing after successful immunotherapy in those who had received immunotherapy compared to those without immunotherapy. And it changed the outcomes after sinus surgery. And this was a good indirect argument for me, at least, to support anti-allergic treatment. There was another question related to the nature and how anti-allergic treatment should be given in these patients with chronic rhinosinusitis. And there I would just follow international recommendations with monotherapy first, nasal steroids, and with and without antihistamines, then combination of anti-allergic treatments, including leukotriene antagonists and or the fixed combination antihistamine and nasal steroids, and as a third step, allergen-specific immunotherapy. There are also some questions related to the central compartment allergic disease, which is this new entity that has been largely overlooked, including myself and some other experts that took part even in the EPOS expert committee. But we all recognize the fact that in some patients, we do see these localized polypoid structures that are not similar to those that we see in the patients with chronic rhinosinusitis and nasal polyps, which affects the bilateral sides and also includes the sinonasal cavities. And we do agree that we need more studies and a better understanding of what this pathology is all about and how we can optimally treat these patients. But it seems very logical that with a nasosteroid as well as with local removal of these polypoid structures, we may achieve a good outcome. Then there is a question on bronchiectasis and to what extent antibiotics may be effective for bronchiectasis and not so effective for chronic rhinosinusitis. Well, there it all is about what do we aim for when we prescribe oral antibiotics. Do we aim to kill the bacteria, or do we aim for a potent anti-inflammatory effect as we see with the macrolides? I often prescribe antibiotics, but mainly aiming for their anti-inflammatory potential rather than for their potential to kill the bacteria. There have been many more questions incoming, and these questions will be put online in the platform that will be disseminated in due time about EPOS 2020 webinars. But for the sake of time and also out of respect for the next speaker, we need to proceed with this webinar now because we want to close in time. And it's my great pleasure and honor to introduce to you Dr. Sietze Reitsma of the Academic Medical Center in Amsterdam. He's a rhinologist working there, seeing also patients affected by chronic rhinosinusitis, and he will guide us through this unique chapter of EPOS 2020.
Well, thank you very much for this opportunity to present some of the work we've been doing in the EPOS group on pediatric CRS. And in this 15 minutes, I would like to briefly take you through the main points. And maybe you're thinking, well, we've had these other presentations already. I'm feeling a little bit tired. If anything, I would like you to remember one thing when it comes to the child with CRS. And basically, it's just this question mark. And as we go through the presentation, I'll hope to explain to you why this question mark is really important. So when you are presented with a child having complaints for a longer period of time, and you are thinking, well, this might be CRS, pediatric CRS, always remember this question mark. So how will we go about it? I thought it would be best in this short period of time just to go over the care pathway we have devised. After a lot of discussion, after reading all the evidence that's out there, all the news that has been performed since the previous version of EPOS, and this is what we have come up with. And the first reason this question mark is really important is highlighted on the right. I would like to point your attention to this triangle. I know the letters are small, we will zoom in later, but the triangle stands for the differential diagnosis. And if you look at this care pathway, you can see that we go through the various level of care. At the top, there's the self-care and the pharmacy level, and the primary care level with the family physician or the general practitioner, depending on your local situation. And the lower half is for secondary and tertiary care. And you see that this triangle is important because once you start at the upper half, you don't really know if a child has CRS, and you should really consider the other differential diagnoses. Important ones, for example, are adenoid hypertrophy or allergic rhinitis or just plain common colds. So keep this in mind, please, because this is what will run through the presentation, this triangle on the right. That's one important point I really want to make. And then if we zoom into the upper half of this care pathway, there's another point I would really like to make before we go in through the flow, what to do with a child with possible CRS. And what I would like to highlight here is this box on the right, the alarm symptoms box. You know it, I hope you all do, but this is really important also for us to teach our primary care physicians even our pharmacists, if any of these alarm symptoms is present, this warrants immediate referral. Something else is going on. Maybe it is CRS, but at least it's complicated CRS. It could be a complication of ARS. Anyway, if any of these alarm symptoms are present, the child should be sent in for immediate workup and, if necessary, surgery, of course. Well, having said that, normally you start with the child simply having complaints. And as you are aware, I hope, then these complaints could be CRS symptoms. The diagnostical construct for children is somewhat different than from adults, especially because children cannot really report loss of sense of smell or taste. So this is replaced by cough. But obviously these complaints can be due to other diseases as well. So if you look at nasal obstruction, if you look at discolored discharge, but also facial pain and pressure or cough, even for a longer period of time, remember the triangle, it could be all sorts of things. And of course, if people are at the self-care level, if they go to the pharmacists, there is not really a way to distinguish these diseases. Of course, you could ask for, is there sneezing, is there seasonal variation, making allergic rhinitis more likely? But it doesn't really matter. Maybe you should say it doesn't really matter therapeutically. So if you visit the doctor, and depending on your country, is it the general practitioner or the family physician or what have you, of course, examination of the ENT area is important, and mainly to rule out one thing or to have a feeling of, is adenoid hypertrophy important? Because if that is the case, you could argue just refer for possible surgical management of this. But if you don't really know, if you're not sure, if you're thinking this is not the case, then all we would suggest is a trial with intranasal corticosteroids. Just give the kid some nasal spray and see what happens. And basically after 6 or 12 weeks, if the child is doing better, just keep it on. And accept that maybe you don't have the accurate diagnosis, but at least you have the complaints controlled. That's the most important part. But if the child does not improve, the complaints are still there, that would be a good reason to refer to secondary and tertiary care. And then we go down to the lower half of the management pathway, the care pathway, looking like this. And we will go through this step by step. And if you remember again, this triangle of differential diagnosis, this is where we start narrowing it down. This is what should be done. So, of course, you do a nasal endoscopy to see if there are any signs of CRS, but also do not neglect the history taking and also the full ENT exam. And what you should be able to do at least is make a division between 3 boxes, which we will go through. Of course, again, adenoid hypertrophy. If you have a child with a blocked nose, snoring, and upon endoscopy you see a huge adenoid, well, let's go for that before calling it CRS. And then roughly either it's not CRS or it might be CRS. So if we zoom in on the adenoid hypertrophy part, that shouldn't be too hard. If you're convinced that that's the problem, that that's causing all the complaints, just go for an adenoidectomy. And important, see if the child is doing better. And of course, if the child is doing better, you can send back to the primary care. And if it's not doing better, then you start thinking again. Again, this question mark, what's going on? Maybe it's not the adenoid, what else could there be? And then you should consider the differential diagnosis again, and if necessary, do some tests. For example, maybe there's allergic rhinitis also at hand, and you do a skin prick test or some blood work. So that's for the adenoid hypertrophy part. Well, the other part that I want to briefly look over, you could just say, listen, this child has complaints, but when I do the full ENT exam, when I take the history, when I look into the nose, I'm convinced it's not CRS. Then again, you could look for other pathologies like allergic rhinitis, or maybe your conclusion simply is this child is having common colds. It's had a few in a short period of time that explains why the complaints are there for a prolonged period, but this is not CRS. It's okay to make this statement, and to be really sure, you can of course test for is there any allergies. You could prolong the use of intranasal corticosteroid spray, but leave it at that. That's fine. But when in doubt, or even better, if you're really sure that there is signs that fit the diagnosis CRS, then we get to the right part of this scheme. And then in children, again, a child with primary CRS, question mark, start thinking again, start thinking again. That's why we put in bold, always consider that this is secondary CRS. And what did we mean already? Like Richard Harvey explained, and as in the EPOS group, we have adapted this way of thinking. You can make a division between primary and secondary CRS, and I've put up the slide for secondary CRS here. And then you look, is it only localized or unilateral or diffuse? Well, in case of children with CRS, if it is secondary, this is the most likely reasons you should at least consider. So, of course, it could be PCD, it could be cystic fibrosis, or something is wrong with the immunity of the child. So before you start doing anything, you really need to check, at least in your mind, am I missing secondary CRS? So send the child to a pediatrician if needed, or any doctor you seem fit to help you distinguish primary from secondary CRS. And then if you have had that step, you start with what we call appropriate medical therapy. Yes, the child has been on intranasal corticosteroids already, but you keep doing that. Maybe go to drops if they are available, and add saline rinses, or in some countries, what people do is dilute the drops into the rinses to get a better distribution of the medication. So you keep at the medical part. So that's the other question mark I want to highlight today. If you have a child, if you have suspicion of CRS, question mark, is it really CRS? Question mark, is it secondary CRS? And then question mark, should I go right for surgery? The answer is no. Stay back, take time, and use appropriate medical therapy first, and of course follow up the child. If after 6 to 12 weeks of appropriate medical therapy the child has not improved, then it seems a good idea to take a CT scan, just to see, am I missing anything, what's going on inside. And here we have decided to make this division. So if on CT scan you see a low Lund K-score, so the paranasal sinus system, for as far as it has developed in this patient, is not really opacified, then we would just say go for an adenoidectomy. And of course, again, followed by appropriate medical therapy. And then if at follow-up the child has improved, then you could say, well, maybe this has been adenoid hypertrophy or some form of adenoid disease inducing CRS-like symptoms, but it's now better, so you leave it at that. The harder part comes when you also see a lot of opacification on the CT scan. Still, then we would not advise to go straight for FES, especially in younger children. Keep it simple, keep it safe. So again, go for the adenoids. They might be a reservoir inducing these complaints. You could do a sinus irrigation. It's relatively easy, it's relatively harmless, and again, appropriate medical therapy. And again, follow up the child. So what do you do if you're convinced that the child has CRS, has had appropriate medical therapy, has had an adenoidectomy, with an irrigation, again, appropriate medical therapy, and does not improve? Well, you see the box on the far right below, just here. We still say, beware, don't go straight for FES. You could consider that in older children, but first, again, the question mark, am I missing something? So check again for comorbidities. Did you really rule out secondary CRS? Is the growth of the child okay? Are there any other medical problems? And sometimes you can just explain to the parents that most of these symptoms will give resolution over time and keep them on medical therapy only. In older children, yes, you can do FES. But if you look at the incidences of CRS in the pediatric population versus the differential diagnosis, it's already not so likely that a child has CRS. And if you go down this way, if you look at the number of children really needing a FES for CRS, that's really, really a small group. So if for the right patients you can do FES, sure, but be really careful. And if you don't do FES in children often, maybe you should consider sending the patient to someone who does, because the anatomy is different. It can be really tricky. So yes, you can FES, but beware. So, having said that, we have gone through this care pathway. I hope I have pointed out some key points. For me, the question mark is the most important, and it could be summarized like this. So, CRS in children is rare. Again, if you think a child has CRS, question mark. Most of the comorbidities are more likely to be present. Common colds, allergic rhinitis, adenoid hypertrophy, so check for these, please. And if you are indeed convinced that it is pediatric CRS, always remember, think about, is it secondary CRS? Am I missing PCD? Am I missing CF? Is something wrong with the child's immunity? Please think about it, and if necessary, check for it. And as I have stressed numerous times, be cautious when indicating surgery. Start small, you can always do more, but start small because that might just be enough. And maybe the most important point missing here would be the hallmark is appropriate medical therapy. So thank you very much for your attention. So thank you for your attention and also for sending in some questions here. The first question I would like to discuss is the question, what do you do when there is no real primary care level? Do you start with a blind trial of intranasal corticosteroids? Well, that's a fair question, of course. We've had some discussion in the EPOS group because per country the care system varies, obviously. If you are in the situation that there is no real primary care level, I would really like to point again to that triangle of differential diagnosis. If a child comes in directly to you without any other physician having seen it, the chances of comorbidities or other diagnoses being present is larger. So you have a larger chance that the child simply has, for example, allergic rhinitis or common colds or whatever. So what I would personally do is still use whatever tools you have to start discriminating between them. You could, of course, say, well, whatever, we will just start with intranasal corticosteroids and I will see you in 6 weeks. But I would rather say use your nasal endoscopy, do the full ENT exam and take some time for history taking. Because if you have the possibilities to narrow down your diagnosis, please do so. That would be best in my opinion. But on the other hand, you could defend simply starting intranasal corticosteroids and following up the child. Other questions that relate to the management scheme is about cutoffs. One question is, do you have a cutoff for low or high Lund-Mackay score in children? Well, we have been discussing this and we chose deliberately not to put in a number because it's not like you follow a recipe and bake a cake. You really also need to rely on your clinical view of the patient. Moreover, there's only little evidence. There's one study that suggests that a Lund-Mackay score of 5 would be a cutoff, but that's one study only. And we would rather have you think the case through, and that's why we chose just to say low or high Lund-Mackay score. And in any way, as I've told during the presentation, be really careful when indicating a real FES in children. And the other question that arose is, what is then the age when you would consider FES in children? Well, the answer here is somewhat the same. There is no absolute cutoff there, but you could say that in a child where adenoid hypertrophy is still a relevant differential diagnosis or a relevant contributor to the pathology, we would rather not perform FES. And well, you could debate, is it 8 years of age? Is it 6 years of age? Is it 10 years of age? I don't have a clear answer there. But we would relate it to the presence of the adenoid or the role of the adenoid. And then the last question I would like to address is, what about post-op care after FES in children versus adults? Are there similarities and what about differences? Well, basically, I don't think there is much evidence out there to point us either way. And there again, I would advise you to keep it patient-centered. So for example, in our own center, the use of nasal dressings or tampons in the nose after surgery in children, if you can, please use absorbable ones. So you don't have to go through with taking them out in the outpatient clinic or giving him another anesthesia to get the tampons out. That would be one hint I would give you. Roughly, other than that, it would be rather the same. And another be careful that I would want to give to you is be careful with oral corticosteroids. We give a lot. We give them regularly to our adult patients, but in children, of course, there are concerns for safety. And I would really advise you to not do it or only do it if you're really convinced that it will help the patient. Rest assured that the other questions will be answered later on our forum. And having said that, I would really love to hand back the stage to Professor Hellings.
Thank you, Sietze. This was a wonderful webinar, according to my opinion, because every single contribution was really valuable, highlighted the novelties of the EPOS 2020 document. And I just would like to thank all of our colleagues who joined this webinar. We had over 1,200 physicians who registered for joining this webinar, which is a great achievement, knowing all the challenges related to COVID-19 and also the missed opportunity to meet in person at the Thessaloniki meeting organized by the European Rhinologic Society. Anyhow, I do thank each of the faculty members also of this third webinar, Professor Claire Hopkins, Deyun Wang, and also Sietze Reitsma, and also all the people from the audiovisual team and Euphoria management team who made it all possible. Just for your information, if you missed some of the information and you would like to have a small rehearsal later today, there is a repetition of this webinar at 5 p.m. that will be led and coordinated by Professor Bob Kern from Chicago, US. I hope to meet you all in person in the context of European Rhinologic Society, and I thank you all for having joined us today.